So imagine this. You walk into a clinic right now, maybe in China, and there is this artificial intelligence venipuncture system just sitting there waiting for you.
Right, just a machine in the room.
Exactly. You sit down, you slide your arm into this device, and immediately this near-infrared light starts scanning your skin.
Sounds a bit like sci-fi, honestly.
It really does. But it's real. And this algorithm, it instantly maps out the exact location, the depth, the volume of your veins. It can actually tell the difference between a vein and like a tendon or muscle tissue.
Wow.
Yeah. And then a robotic arm just slides in and inserts an IV needle. And the craziest part, it operates with over 90% accuracy.
Which is wild because that often outperforms actual seasoned phlebotomists.
Right. It is mathematically precise, there's no friction, and it is completely devoid of any human emotion.
Yeah, it's just pure data.
Exactly. So that brings us to the core question of today's deep dive. If a machine can draw blood perfectly, and an algorithm can diagnose an illness in literally seconds, what exactly is a nurse supposed to do?
That is the big one. It really forces this complete reevaluation of the entire profession. Because if you think about it, if the mechanical tasks, the diagnostic stuff, even the procedural data entry are all just offloaded to software and robotics.
Which is happening.
Right, it is happening. Then the role of the human provider fundamentally shifts. We are looking at this future where the primary function of a nurse might have, well, very little to do with the physical mechanics of medicine.
Oh, interesting. So what replaces it?
It becomes all about the psychological, the cultural, and the emotional architecture of healing.
The architecture of healing, I like that. And that tension, right, between this cold, precise edge of digital innovation and the really messy, subjective reality of human empathy that is our mission today.
Absolutely.
We're looking at how the nursing profession is actively trying to re-engineer itself. And we've got a really fascinating stack of sources on the table today to guide us through this.
A really diverse stack, too.
Yeah. We've got an academic analysis on how programs are actually using live theater actors to teach cultural competency.
Which is so cool.
It is. And we also have some incredible insights from David Benton. He's the former CEO of the National Council of State Boards of Nursing. He dives deep into the integration of artificial intelligence. And finally, we have these detailed academic texts on the cognitive burden of navigating electronic health records.
You know, the dreaded EHRs.
Yes, we all know them.
But the thing is, this matters profoundly to you, the listener. Whether you work in healthcare administration or maybe you write software, or even if you're just a patient sitting in a waiting room right now.
Everyone is touched by this.
Exactly. The entire scaffolding of how you receive care is being quietly redesigned right under our noses. By the end of this conversation, the invisible systems operating during your next doctor's appointment, I mean, from the way the clinician positions their chair to the algorithm running quietly in the background, it's all going to become glaringly obvious to you.
It really changes how you see a clinic. So the urgency behind all this redesign, according to our sources, seems to be tied to a very specific timeline.
Right, the demographics.
Yeah, the demographic projections point to the year 2044. That is the moment the United States crosses the threshold into becoming a minority-majority nation.
Which is a massive shift.
Huge. The landscape of who is actually seeking care is fundamentally changing. And that means the baseline assumptions built into traditional medical training are, well, suddenly totally outdated.
They are entirely outdated. I mean, the traditional nursing curriculum was built for a largely homogenous population. But as we shift toward this unprecedented diversity, educators are running into this severe methodological wall.
A wall. How so?
Well, the academic authors we're reviewing today, Karnichnik, Eddy, and Schwartz, they highlight this core deficit. You simply cannot teach human empathy or cultural sensitivity through didactic memorization.
Right, you can't just memorize flashcards for empathy.
Exactly. Textbooks are excellent for teaching the what of human anatomy, like here is the femur, but they are entirely inadequate for teaching the how of human connection.
Because, I mean, knowing the definition of a cultural practice doesn't actually prepare you for the real-time emotional reaction of a patient who's in distress.
Not at all.
It's kind of like reading about cultural competency in a textbook is like reading a manual on how to swim and then just being shoved into the deep end of a pool during a storm.
That's a great analogy.
The theory just evaporates the moment you hit the water or, the moment you encounter actual human friction.
Precisely. And in a clinical setting, that friction often manifests as a misinterpretation of culturally influenced behaviors.
Okay, give me an example of that.
So, the literature points to a classic one, an aversion to physical touch. In certain populations, if a patient pulls away from a clinician's touch, that might stem from deeply ingrained historical trauma or maybe just very specific cultural boundaries.
Which makes total sense.
It does. However, a nurse who has only been trained in a rigid, standardized Western model, they might document that physical withdrawal as patient non-adherence.
Oh, wow. Which instantly criminalizes the patient's trauma in their own medical record.
It's exactly.
The nurse just assumes, oh, the patient is being hostile or they're uninvested in their own healing, when in reality, the patient is having a completely natural physiological response to a perceived threat.
Right. And once that label of non-compliant or difficult is entered into their chart, it follows them everywhere.
It alters how the next doctor treats them. It alters how their insurance views them.
Yeah, it is a massive empathy gap that translates directly into a tangible reduction in the quality of care.
Yeah.
It creates this cascading failure of trust.
So if I'm playing devil's advocate here or just putting myself in the shoes of an educator, how do you actually grade empathy?
That is the dilemma.
Right. Because you have to test these students. But how do you test something so deeply subjective without risking actual patient harm? You can't just use marginalized populations as, like, practice dummies for empathy training.
No, you absolutely cannot. And that brings up a massive structural problem. If you're running a nursing program, you have to be able to quantify a student's competency before you let them graduate.
So what's the solution?
The solution they came up with is actually a brilliant adaptation of high-fidelity simulation. But instead of using those really expensive animatronic mannequins that breathe and blink—
The ones that kind of look like horror movie props.
Yes, exactly those. Instead of those, they introduced standardized patient actors. The nursing programs actively partnered with university theater departments.
That is so smart.
Isn't it? They bring in trained actors to role-play highly specific, culturally complex clinical scenarios.
And this creates what the researchers refer to as a safe space to fail, which, from a neurobiological learning perspective, is critical, right?
Oh, absolutely vital.
Because when a student is terrified of causing actual physical harm to a living patient, their cognitive load is entirely consumed by anxiety.
That frees up.
Yeah, they just default to whatever mechanical checklist they have memorized. But by removing the risk of actual patient harm, the student's brain can engage in higher-order problem solving.
They can take a conversational risk.
Right. They can misinterpret a cue, say the wrong thing, and see the immediate emotional fallout on the actor's face, all without ruining a real person's day or health.
Exactly. The simulation itself is really just stress inoculation. The actual learning occurs immediately afterward during the debriefing.
The debriefing is key.
It is. The instructor and the student sit down and they deconstruct the interaction frame by frame. Based on DEI principles, too, they asked, why did the patient shut down when you asked about their diet?
Or, what did your body language communicate when they brought up their home life?
Yes. It takes these completely abstract concepts and grounds them into tangible, observable behaviors.
It makes perfect sense on a theoretical level. But to really grasp how this rewires a clinician's brain, we need to look at the specific localized scenario the researchers designed in the source material.
The context here is everything.
It really is. So they built the simulation for a program in northern Arizona. This is a predominantly rural, medically underserved region that borders the Navajo Nation.
Which is the largest American Indian tribe in the United States.
Right. And the geographical and statistical reality of this specific region is just, it's staggering. It heavily dictates the kind of care a nurse has to provide.
It's not a standard urban clinic environment at all.
No. Let's look at the data the sources provided on this area because it paints a really stark picture of systemic failure. The stats say 15 to 17% of patients in this region simply cannot access healthcare.
Nearly 1 in 5 people.
Yeah, geographically or economically locked out of the system.
Whew.
Furthermore, 10% of the population cannot fill their prescriptions due to cost.
That is devastating.
They sit in the exam room, they get a diagnosis, they take the piece of paper that could literally cure them, and then they abandon it because the financial math just doesn't work.
These are the social determinants of health in action. The medical issue is often completely secondary to the logistical and economic barriers.
It's the environment.
Exactly. The physical distance to a clinic, the lack of transportation infrastructure, the systemic poverty, these factors are stacked against the patient long before a pathogen ever enters their body.
And the most glaring determinant highlighted in the research is food access. The entire Navajo Nation is classified as a food desert.
Which has massive physiological implications.
Huge. To put that in perspective for you listening, the national average for food insecurity sits around 11%. In rural Arizona, generally, it climbs to nearly 16%. But on the Navajo Nation, food insecurity affects 76.7% of households.
Almost 77%. That is just
It's unbelievable.
And we have to examine the physiological cascade that results from that specific environmental deficit. A food desert doesn't just mean people are hungry.
Right. It's about what they can eat.
Exactly. It means the only calories available are highly processed, calorically dense, and nutritionally bankrupt. When nearly 77% of households are forced to rely on that specific caloric profile, it triggers an absolute epidemic of chronic metabolic disease.
The numbers back that up.
They do. The obesity rate in this population is an astonishing 85.2%.
85.2%. And obesity is the catalyst for so much else. The data shows that this specific environmental reality makes the risk for type 2 diabetes 2.5 times greater than the general population.
Which predictably drives up rates of hypertension, cardiovascular disease, neuropathy.
So you cannot simply hand a patient in this demographic a pamphlet on, eating leafy greens and consider your job done. The leafy greens do not exist within a 50-mile radius of their home.
Which is exactly why the faculty had to design a simulation that forced students to confront these exact barriers. It is not enough to diagnose the symptom.
You have diagnosed the environment.
Yes. And that imperative led to the creation of the standardized patient scenario featuring Dakota Eddy.
Let's talk about Dakota Eddy. This scenario was developed in direct collaboration with Navajo nursing faculty, right? To ensure absolute authenticity.
Yes, very intentionally designed.
So, put yourself in the shoes of the nursing student, you review the chart, and you walk into this simulated exam room. You are introduced to Dakota Eddy, who is a 19-year-old male actor.
Right.
And on paper, his chief complaint is incredibly routine. He has had a cough for 3 days, moderate congestion, a runny nose, and he reports massive pain when swallowing.
Now, if a student is operating purely on a mechanical Western medical framework, they are already formulating a plan before they even sit down.
Oh, for sure. They're thinking, okay, strep throat or a viral upper respiratory infection.
Exactly. They just want to order a rapid swab, prescribe an antibiotic, and move to the next room. That's the reflex.
But the simulation is designed to actively resist that mechanical approach. The actor playing Dakota Eddy is trained to exhibit specific nonverbal cues. He has darting eyes.
He's anxious.
Yeah, he is mildly agitated. His breathing is rapid. He mentions casually that his diet has been highly erratic for months and that he has suffered from severe insomnia ever since moving off the reservation.
Lots of red flags.
Tons.
Yeah.
And then he offers one critical piece of information. He states that he regularly sees both a Western doctor and a traditional medicine doctor at the local Kayenta Health Center.
And that right there is the pivot point of the entire simulation.
The throat pain is the decoy.
It is entirely a decoy. The real assessment is whether the nursing student can navigate his visible anxiety without dismissing it, and whether they can validate his use of culture-based health treatments.
Here's where it gets really interesting. The authors of the academic paper framed this exact moment as an exercise in decolonizing content.
That's a powerful term.
It really is. They argue that traditional medical education relies on this rigid Western ideology of scientific superiority, this idea that the hospital's way is the only valid way.
Right, the we know best mentality.
Exactly. So according to the authors, a student who ignores Dakota Eddy's mention of a medicine doctor or dismisses it as like unscientific folk medicine, that student is actively perpetuating a colonized approach to care.
By designing a scenario where success requires validating the traditional medicine doctor, the authors are attempting to force the student to actively dismantle that hierarchy.
They have to meet the patient precisely where their belief system resides.
And that framework dictates exactly how the interaction is graded during the debriefing. The faculty aren't just checking boxes to see if the student ordered the right throat swab.
Right. The swab doesn't matter as much.
Exactly. They evaluate whether the student applied specific actions demonstrating equitable care. Did the student build rapport despite the patient's agitation?
Did they explore the systemic reasons behind his Erratic diet, acknowledging the food desert.
Yes. And most importantly, did they construct a care plan that integrated his traditional practices rather than alienating them?
Because if the student succeeds at all of that, they have just executed an absolute masterclass in human connection. They've looked past the sterile data of a cough, navigated this incredibly complex socioeconomic web of food insecurity and historical trauma, and they build genuine trust with a highly anxious 19-year-old.
It is a profound, beautifully empathetic interaction. It is the absolute ideal of nursing practice.
It is, but
Yes.
it immediately crashes into the harsh structural reality of modern healthcare.
Here we go.
Right. Because in a modern hospital setting, if that profound empathetic interaction isn't meticulously coded and entered into a database, legally and financially, it simply never happens.
If it isn't documented, it's a ghost.
Exactly. So our amazing nursing student has to take all that nuanced human connection, physically turn away from Dakota Eddy, and stare into the glowing interface of an electronic health record.
The third wheel in the room. The EHR.
It really is.
The transition from that deeply human art of empathy to the rigid data architecture of the EHR is one of the most jarring cognitive shifts required in medicine today.
It's awful as a patient, too.
Oh, completely. But to understand how the computer became this third entity in every exam room, we have to look at the historical context outlined in our textbook sources.
Right. How did we get here?
Well, this wasn't a gradual, organic evolution. It was a massive, federally mandated technological shock to the system.
The text points to the early 2000s for this, right? President George W. Bush issued a mandate in 2004, and the goal was to make electronic health records accessible to most Americans within a decade.
That was the catalyst.
Yeah, and that was followed up in 2009 by President Obama. He signed the American Recovery and Reinvestment Act into law, along with the HITECH Act.
Which came with a lot of money.
A ton of money.
Huh.
These legislative moves effectively flooded the healthcare system with massive financial incentives to adopt health information technology. And at the same time, they were penalizing facilities that failed to digitize.
So hospitals had to move fast, and the sheer speed of that rollout completely outpaced the educational infrastructure.
They weren't ready.
Not at all. Hospitals were installing incredibly complex, frankly poorly designed software systems and just forcing clinicians to use them overnight.
And so a massive competency gap emerged, not just for practicing nurses, but for the students coming through the pipeline.
The textbook details how early attempts to teach EHR navigation were spectacularly ineffective. Medical and nursing programs relied on didactic classroom lectures.
Wait, they taught software in a lecture hall?
Yes. Students would sit in a lecture hall, look at a projector screen, and literally just watch an instructor click through drop-down menus on the software.
That is absurd.
It is a fundamental failure of context-dependent memory. The research by Biagioli and colleagues cited in the text demonstrates this perfectly. They found that medical students who received classroom instruction on an EHR 14 months prior to actually using it in a clinical simulation,
Yes.
they retained almost none of the required knowledge.
Zero retention, which is entirely predictable. I mean, software navigation is a motor skill as much as it is a cognitive one.
Absolutely.
Teaching a student how to use an EHR via a PowerPoint presentation is like, it's like teaching someone to play the piano by showing them photographs of the keys.
And then just saying, good luck.
Yeah, right. When they finally sit on the bench, they have no muscle memory. And we have all been the patient in this scenario, right? We've all experienced the fallout of this.
Absolutely.
Is there anything more awkward than sitting there in a paper gown, pouring your heart out about your health, trying to explain a really vulnerable symptom, while your provider's just aggressively clicking a mouse, glaring at a monitor, and occasionally muttering, "Ugh."
It's the worst. The technology, instead of facilitating care, becomes a physical and psychological barrier.
It totally does.
Oh, yeah.
So how do educators teach students to use this massive digital tool without it becoming that barrier?
Well, the provider in that scenario is experiencing massive cognitive overload. Their brain is attempting to process the patient's auditory narrative while simultaneously battling a clunky user interface to find the correct diagnostic code.
Right, they're fighting the machine.
Exactly. And when cognitive load maxes out, eye contact drops, active listening ceases, and empathy plummets. Therefore, the educational challenge isn't just teaching students which buttons to click. It is teaching them how to manage the presence of the machine without sacrificing the human in the room.
And this is where the textbook introduces this highly intentional communication framework. It's called the Respexy method.
Yes, the respects method.
It's basically a behavioral algorithm designed to mitigate the alienating effects of the computer. It attempts to weave the data entry seamlessly into the social interaction.
It breaks down the interaction into manageable, highly choreographed steps. We should go through the acronym.
Let's do it. So the R stands for review.
The imperative here is to review the EHR prior to entering the room. The provider must internalize the chief complaint, the vital signs, and the problem list before they ever touch the door handle.
Because if you walk in cold and you immediately bury your face in the screen to figure out why the patient is even there.
You instantly communicate that the database is more important than the human being.
Exactly. The first impression is completely severed, which leads perfectly to the EON entrance.
The framework dictates that you greet the patient, establish eye contact, and build rapport before you ever log into the terminal.
You establish human primacy. I love that.
Then comes the S, which stands for say. This is a crucial auditory tool. The provider must narrate their actions on the computer.
Oh, like talking out loud while typing.
Exactly. Instead of typing in silence, they say, I am just pulling up your lab results from your last visit, or I am entering the dosage for this prescription.
The psychology behind that is fascinating to me because in a high-stakes environment like a medical clinic, silence is a vacuum. And a patient's anxiety will immediately fill that vacuum with worst-case scenarios.
Oh, absolutely.
Right? If a doctor frowns at his screen and types silently for 2 minutes, the patient assumes, oh my God, they've discovered a terminal illness.
They're writing my obituary.
Exactly. But narrating the process removes the mystery and regulates the patient's nervous system. Okay, next is P for position.
Position the computer so the patient can actually see the screen. This creates what the literature calls the patient-provider EHR triad.
A triad.
By angling the monitor, the computer ceases to be a wall between the two parties and becomes a shared focal point. You are looking at the data together as a collaborative team.
It changes the geometry of trust in the room.
It really does.
The second E in respects is for engagement position. This dictates that during critical or sensitive moments of the conversation, the provider must completely disengage from the hardware.
Hands off the keyboard.
Hands off. They must turn their body fully toward the patient and maintain direct eye contact, because you cannot deliver a complex diagnosis while looking over your shoulder at a keyboard.
You just can't. Next, the C stands for computer confidence, which addresses the transference of trust. Providers are instructed to speak positively about the EHR system. They must avoid blaming the technology for delays or errors.
See, this one makes complete sense from a patient perspective. Because if my nurse sighs and says, this stupid system keeps deleting my notes, my confidence in that hospital's ability to safely manage my healthcare completely plummets.
Of course it does.
If the professionals don't trust the system holding my medical data, why should I?
Exactly. You project confidence in the tool to maintain confidence in the institution. Moving on, the T is for teach.
Peach.
The provider uses the visual data on the screen, so things like graphs of blood pressure over time, trend lines of cholesterol to actively educate the patient. It transforms a static record into an interactive learning tool.
That's a great use of the monitor position we talked about.
Exactly. And finally, S is for summarize. The provider verbally summarizes the action plan while typing the final notes and then physically logs out of the system.
Simultaneously signing out.
Right. It signals that the administrative task is complete and the patient once again has their undivided attention.
Review, entrance, say. Position, engagement, computer confidence, teach, summarize. It is a brilliant behavioral scaffold.
It really is.
But the textbook also makes it clear that just memorizing the acronym isn't enough, right? Students have to practice the physical interface. And the sources detail a fascinating case study regarding a program called the simulator.
Yes. This was an attempt to merge the clinical simulation with the software simulation. They put students in a simulated environment and tracked their ability to actually navigate the digital forms while interacting with the clinical scenario.
And the initial data on this was alarming.
Very alarming.
During the first round of testing, students struggled massively just to retrieve basic forms. And only 72% of the clinical tasks were documented correctly.
A 28% error rate in medical documentation is a systemic crisis.
It's terrifying.
In a real-world environment, a failure to document a medication allergy or correctly code a symptom doesn't just stay in the computer. It directly translates to catastrophic medication errors, misdiagnoses, and severe patient harm.
But luckily, the researchers didn't accept that failure rate. They engage in rigorous usability testing. They analyzed exactly where the student's cognitive load was maxing out.
They looked at which menus were confusing.
Right. Which drop-downs were counterintuitive.
Yeah.
They modified the simulator's interface based on that behavioral data and ran the cohort through again.
And the results were completely different.
Completely. After the modifications, documentation accuracy leaped to 95%.
From 72 to 95.
Huge jump. User satisfaction increased, and the time required to complete tasks plummeted. It proves that you cannot divorce the technology from the empathy. They have to be trained in tandem.
Exactly. By making the software navigation second nature, they reduce the cognitive load required to use it. The less brainpower a nurse have to dedicate to finding a button on a screen, the more brainpower they have available to read the micro-expressions on Dakota Eddie's face.
It is entirely about freeing up cognitive bandwidth. However, this is a big however, everything we have discussed regarding the electronic health record assumes the computer is fundamentally a passive tool.
Right, a filing cabinet.
An incredibly complex, highly organized electronic filing cabinet, sure, but it requires human input to function. It doesn't think.
Not yet.
But that paradigm is fracturing. What happens when the tools in the room evolve from static databases into active, predictive, thinking partners?
And this brings us to the most disruptive force in modern healthcare, and really the focal point of David Benton's analysis, the integration of artificial intelligence.
This is where it gets wild.
It does. Benton, having led the National Council of State Boards of Nursing, possesses this macro-level view of how this technology is rewriting the operational code of the entire profession. And he emphasizes that AI is not a hypothetical future state. It is aggressively infiltrating nursing across 3 distinct sectors right now.
Okay, let's unpack this. Let's examine those 3 sectors, starting with education, because it circles back perfectly to the simulation strategies we just unpacked.
It ties in beautifully.
Benton points out that AI is fundamentally altering how clinical scenarios are generated. Historically, an educator had to manually write the script for a standardized patient actor, or maybe pre-program a rigid decision tree into a computer module. But now, AI is creating highly tailored, dynamic simulation systems.
We are seeing the integration of large language models into medical training. A student can interact with a virtual patient powered by an AI.
And because the system isn't running on a static script, it dynamically reads the student's prompts and alters the patient's physiological and conversational responses in real time.
Exactly. So if a student asks a highly empathetic, culturally aware question, the AI patient algorithmically lowers its simulated anxiety metrics and offers more detailed medical history.
Oh, that's amazing.
But if the student uses abrasive or dismissive language, the AI patient becomes defensive or non-compliant. And it is doing this while simultaneously scoring the student's clinical logic and identifying their specific cognitive blind spots.
It creates an infinitely scalable, highly individualized learning environment. And this is critical because nursing faces a massive systemic shortage of qualified faculty.
You simply do not have enough human professors to sit one-on-one with every student for hours of simulated practice.
No. But a sophisticated AI system can provide bespoke clinical scenarios to 1,000 students simultaneously. It identifies exactly which students are struggling with cultural assessments and which are failing their pharmacological calculations.
It's a game changer for education. The second sector Benton identifies is management. He points to AI's ability to instantly manipulate vast amounts of operational data.
Anyone who has worked in hospital administration knows that staffing a nursing floor is a logistical nightmare of epic proportions.
Oh, it's a giant puzzle.
You are balancing patient acuity, nurse certifications, legal ratio mandates, and human variables like sick calls. Benton notes that AI algorithms can optimize those schedules in milliseconds, predicting patient load surges and allocating staff with a mathematical precision a human manager could never achieve.
But the true paradigm shift occurs in the third sector, clinical practice. This is where the algorithm leaves the administrative back office and directly intersects with patient biology.
And the examples Benton cites in the source material are staggering. We mentioned it at the very beginning of the deep dive. He talks about AI systems currently operating in Illinois that are scheduling and coordinating highly complex cancer treatment services.
Navigating the intricate timing of chemotherapy, radiation, and surgical interventions.
But the example that truly disrupts our understanding of clinical boundaries comes from Asia. He details the AI venipuncture systems being utilized in China.
This is a perfect example of robotics and AI merging to replace a tactile, highly skilled human action.
The mechanics of it are fascinating. As we said, the machine uses near-infrared imaging to scan the patient's arm. But it doesn't just look at the surface. The AI analyzes the subcutaneous architecture to identify the exact location, trajectory, and depth of the veins,
It assesses the blood flow and selects the optimal insertion point.
completely bypassing the human challenge of a hard stick or rolling veins. Then a robotic armature inserts the IV needle. The data shows it operates with over 90% accuracy.
Frequently outperforming human clinicians, which forces us to confront the core existential question of modern nursing.
Right, if a machine can physically locate a vein and start an IV with greater precision than a human,
If an algorithm can analyze a pathology report and coordinate a cancer schedule faster than an oncologist,
and if an AI can evaluate a student's empathy better than a professor,
hmm,
what is the intrinsic value of the human nurse? Are we just replacing nurses? Are we simply marching toward a fully automated robotic healthcare system by 2044?
Benton addresses this anxiety directly by insisting on a crucial distinction in terminology. He argues that in the current healthcare landscape, we should not refer to this technology as artificial intelligence.
What should we call it?
The proper legally and ethically accurate term is augmented intelligence.
Augmented versus artificial.
The distinction is paramount for both professional ethics and public trust. The term augmented implies that the technology exists to support, verify, and enhance human decision-making, not replace it.
So the AI venipuncture machine might map the vein and guide the needle, but a human clinician still must authorize the procedure and monitor the patient's reaction.
Exactly. An AI might analyze an X-ray and highlight a microscopic shadow, suggesting an early-stage malignancy, but the human doctor makes the final diagnostic call. The ultimate authority, and therefore the ultimate legal and moral liability, remains with the human being.
He is a comforting framework for the present moment. He keeps the human at the top of the hierarchy. But Benton himself immediately pokes a hole in that comfort.
He poses a profound ethical dilemma about the very near future.
He asks a question that frankly disrupts the entire concept of clinical authority. He says, as a human, would you overrule the machine when you know it's going to get it right 99.99% of the time? And a human gets it right only 90% of the time.
It is the ultimate paradox of automated medicine. If the longitudinal data conclusively proves that the algorithm misdiagnoses patients significantly less often than the human doctor, does the human doctor still have the ethical right to overrule it?
Human ego insists, I am the trained professional. My intuition matters.
But medical ethics dictate that you must pursue the safest possible outcome for the patient.
If the machine is mathematically proven to be safer, overruling it becomes an act of hubris, not care. I mean, if I am the patient lying in the bed, I do not care about the doctor's ego. I want the 99.99% accuracy.
Exactly. It entirely inverts our understanding of who is augmenting whom. Will the doctor of the future merely be there to rubber stamp the superior decisions of the machine?
That's a scary thought.
It is. However, Benton is incredibly careful to map out the severe dangers of assuming the machine is always right. Algorithms are not infallible deities of logic. They are mirrors.
Mirrors. Yeah. That's a great way to put it.
AI learns by ingesting massive data sets. And as our discussion about Dakota Eddy and social determinants highlighted, historical healthcare data is inherently flawed.
It is riddled with systemic biases against minority populations, marginalized groups, and rural communities.
This is a critical mechanical reality of machine learning. If you feed an AI decades of medical records, where patients from a specific socioeconomic zip code were routinely undertreated for pain due to implicit racial bias,
the AI does not recognize that as a historical failing.
No, it recognizes it as a data pattern. The algorithm assumes the historical data is the correct baseline. Therefore, it will automatically begin recommending lower doses of pain medication for patients from that zip code.
It doesn't just learn the bias, it institutionalizes it, scales it, and hides it behind a veneer of objective mathematics. The bias becomes automated and invisible.
And beyond bias, the sources also highlight the mechanical flaw of confabulation, often referred to as AI hallucination.
Oh, right, when it just makes things up.
Exactly. Early iterations of large language models, when queried with complex medical scenarios, would occasionally generate completely fabricated answers.
But they sound so convincing.
That is the danger. The AI doesn't express doubt. It delivers the hallucinated, incorrect medical advice with absolute structural confidence. If a novice nurse relies on that output without the clinical experience to recognize the error, the results are fatal.
While the sources note that newer generations of AI, like ChatGPT-4, are increasingly sophisticated at mitigating these hallucinations, the fundamental risk remains.
Which is the exact reason Benton argues that the nursing profession cannot adopt a passive posture toward AI.
Nurses cannot wait for software engineers in Silicon Valley to hand them a finished product and tell them how to use it.
They must be deeply integrated partners in the development, coding, and continuous auditing of these algorithms to detect where the hallucinations and biases are hiding. They need to be at the table determining what data the algorithm is ingesting in the first place.
But despite these profound ethical risks and the sheer disruption of the technology, Benton ultimately frames the integration of AI as a massive, perhaps existential benefit for the nursing profession.
And his reasoning circles back to the defining crisis of the modern healthcare system: burnout.
The workforce data is unambiguous. Nurses are leaving the profession in unprecedented numbers. The cognitive load of navigating clunky EHRs, the physical exhaustion of massive patient ratios, and the emotional toll of the work are entirely unsustainable.
Benton offers a quote in the source material that really serves as the thesis for the future of the profession. He states, "If nurses are asked to do things that technology could do more efficiently or more effectively, there's no need for nurses to be doing that kind of work."
It is a blunt assessment, but structurally, it is profoundly liberating. Think about the daily reality of a floor nurse. If an AI system can instantly chart the vitals, automatically cross-reference a dozen medications for obscure chemical interactions, dynamically optimize the floor schedule, and robotic systems can precisely execute routine physical tasks like drawing blood.
What is actually left for the nurse to do?
Exactly.
What is left is the core of the profession. Stripping away the mechanical, robotic, high-stress data entry tasks allows the nurse to reclaim the cognitive bandwidth necessary to execute the incredibly complex human interactions we discussed at the very beginning of this deep dive.
It allows them to pull up a chair.
Yeah.
It allows them to look a patient like Dakota Eddy in the eye, recognize the darting eyes, validate the anxiety, and navigate the cultural complexities of his reality without constantly worrying that they are falling behind on their documentation.
The machine handles the data, so the human can handle the healing.
That's a beautiful way to phrase it.
Benton actually provides a brilliant historical analogy to demystify this. He points to the mercury thermometer.
The glass ones.
Yeah. Decades ago, taking a patient's temperature was a time-consuming, specific mechanical skill. The nurse had to physically manage the glass, read the mercury level, and record it. Today, a digital thermometer registers the data instantly and beams it directly into the EHR.
And no nurse today feels that their professional identity has been diminished because a digital thermometer does the job faster.
Exactly. AI must be viewed through that exact same lens. It is simply the next iteration of the thermometer. It is a highly advanced tool designed to partner in the delivery of care, not a replacement for the caregiver.
That is the perfect synthesis of the massive amount of ground we have covered today. We began by looking at a rapidly diversifying nation, examining how nursing programs are literally hiring university theater actors to teach students the delicate, deeply subjective, and vital art of cultural empathy and decolonized care.
We navigated the clunky, cognitively exhausting realities of learning to type into an electronic health record.
While utilizing the respects method to desperately maintain eye contact and human trust. And we ended by looking over the horizon at a future where artificial intelligence handles the routine logistics, the scheduling, and the mathematical diagnostics.
Theoretically allowing nurses to finally breathe, step away from the glowing screens, and actually be fully present with the vulnerable human beings sitting in front of them.
It is a profound structural evolution. And for you listening to this right now, the implications are entirely practical. The next time you walk into a clinic or a hospital room, I encourage you to actively observe the invisible scaffolding that dictates your experience.
Notice the specific angle the provider chooses when they position the computer monitor.
Recognize that they likely underwent hours of intense simulation training just to know how to phrase a question about your background or diet without triggering a defensive response.
And understand that behind the scenes, there are incredibly complex algorithms quietly cross-referencing your data. It is a vast, interconnected web of human empathy and digital precision, all actively engineered to make your care safer, more accurate, and more deeply personalized.
It is all operating right there in the room with you, hiding in plain sight. But I want to leave you with one final, lingering thought to mull over as you go about your day. It builds on the ultimate trajectory of David Benton's technological vision.
Let us project ourselves fully into that hospital room in the year 2044.
If we reach a point where AI eventually perfects all the diagnostics, manages all the scheduling, effortlessly handles the charting, and robotics execute physical tasks like venipuncture with flawless precision, does the very definition of the word nurse fundamentally change?
That's a massive question.
If the machine becomes the undisputed master of clinical mechanics, does the primary role of a healthcare provider become almost entirely untethered from physical medicine, evolving into a profession exclusively dedicated to cultural, emotional, and psychological connection?
Is the nurse of the future less of a biological mechanic and entirely a professional of human connection?
Keep questioning, keep learning, and keep looking deeper.